Please welcome to the stage the Provost of the University of Washington, Tricia Serio.
Thank you all, and welcome to the annual University Faculty Lecture. As you just heard, I'm Tricia Serio, Provost and Executive Vice President for Academic Affairs. Whether you're attending in person or online, thank you for taking the time this evening to join us in recognizing faculty excellence. I'll start by acknowledging the Coast Salish people of this land I stand on, land which touches the shared waters of all tribes and bands within the Suquamish, Tulalip, and Muckleshoot nations. I'm going to give a special welcome to Zoe Barsness, our regent, who's here in person in the audience, and also to Regents David Zeke and Polo Hernandez, who I believe are joining us online today. The University Faculty Lecture was established in 1976, and it honors a current or emeritus faculty member whose research, scholarship, or art is widely recognized by their peers and whose achievements have substantially impacted their profession, the research or performance of others, and possibly society as a whole. The award is one of the highest honors bestowed upon our faculty. Selected by their fellow faculty members, each recipient is invited to present their work to the university community. Past recipients have included artists, global health experts, physicists, and anthropologists. And this year's recipient is Dr. Douglas Wood, the Henry N. Harkins Professor and Chair of the UW Department of Surgery. Lung cancer kills nearly 125,000 Americans each year, more than breast, colon, and prostate cancers combined. Dr. Wood has spent his career changing that, including today. He's coming to us tonight from having performed surgery today, so he's had a busy day. As a world-renowned thoracic surgeon, he saved the lives of individual patients. As a national leader in the development and expansion of lung cancer screening, he has saved the lives of thousands more. Dr. Wood's leadership in developing and promoting lung cancer screening guidelines has been nothing short of transformative. Through his service as the founding chair of the National Lung Cancer Screening Panel, Dr. Wood has overseen the creation and continual refinement of evidence-based guidelines, which screening programs follow to detect cancers early, when they're easiest to treat and more likely to be cured. These guidelines are now the standard in clinical practice throughout the world. His efforts were pivotal in securing Medicaid coverage for low-dose computed tomography screening, eliminating financial barriers for high-risk populations. This policy shift has led to increased screening uptake and earlier cancer detection, contributing to a decline in lung cancer mortality. Today, Dr. Woods will discuss the many ways he and his colleagues are raising lung cancer awareness, increasing access to early detection, and ultimately working to change lung cancer victims to lung cancer survivors. Please join me in welcoming our university faculty lecturer, Dr. Douglas Wood.
Well, thank you, Provost Serio, for a kind introduction, and you covered most of the territory, so I'm not sure I can shorten a lot of this. Thank you for a generous introduction, and it truly is an honor to give this year's faculty lecture and a chance to go over some of the arc of my career over the past 15 years and the impact that it has had and the effect that I've been able to be involved in with incredible partners from radiologists to pulmonologists and to patient advocates in this effort to decrease mortality from lung cancer. And I want to start with a story. And my story is about Barbara. And the story starts 10 years ago. So 10 years ago, I was in my clinic, and I was running late. I don't know if any of you have been in your doctor's office and waiting in the waiting area and wondering how long you're going to wait and being kind of frustrated. Well, I was the doctor that day. I was over an hour late. I was apologizing to each patient as I went in to see them. And my nurse came to see me and she said, "Dr. Wood, there's one of your former patients here to see you, and she does not have an appointment. What should I do?" And I mean, she could see the distress in my eyes, and she said, "Well, Dr. Wood, I think you should see her." And I said, "Of course, put her in a room, I'll see her." And I walk into the room, and there's Barbara. And she says, "Dr. Wood, I know I didn't have an appointment today, but 10 years ago today, you saved my life. And I wanted to come and thank you and celebrate together." So I can still get teary about that. I had tears in my eyes there, she did, we hugged each other. And we took this photo, Barbara and me, 10 years ago, looking healthy, strong, happy, a cancer survivor. And I remembered a little more detail then that 10 years earlier, 2006 is when I operated on Barbara. She was felt to have a cancer that was not a candidate for surgery or radiation. She would not have been cured by chemotherapy, and she was told to get her affairs in order. And she had actually started to make funeral arrangements. And she's 10 years later, and we're in our clinic celebrating being a cancer survivor. So that is why I do what I do. I think, and I talk to our residents and students and my colleagues and say, what a privilege it is to have the honor of caring for people and to actually have something that matters so much that we get to do something that helps people live better and live longer. I don't think it gets better than that. And I want to give you some good news. And the good news is that we've been breaking records in cancer survival in the United States. Year over year, decreasing cancer mortality by 2.2% this year, and the following year, 2.4%, setting a new record. And in fact, if we look at the past 30 years, that's been about a 31% decrease in cancer mortality in the United States. And you can then calculate what that means. That means approximately 3.2 million cancer deaths averted in the United States over the past 30 years. That's pretty great. 3.2 million Barbaras. And of course, there's a lot of reasons for this. We've had several advances. The best one is cancer prevention. The best thing at all is if people don't get cancer. But there's also early detection, and that's what a majority of what I'm going to be talking about. Picking up cancer early enough when we can do something about it and do it simply and with less invasively. But I have some of my surgical colleagues here. There have been surgical advances over the past 30 years. We have our radiation colleagues that have been revolutionizing how we can radiate people. And my medical oncology colleagues that give systemic therapy that most of you think of as chemotherapy. But it's more than chemotherapy. We now have targeted therapy and immunotherapy, and we have some people with advanced disease that are living years, even with advanced cancer, because of the advances that are happening in medical oncology. But I want to emphasize what are the biggest drivers of that cancer mortality reduction? Well, number one, fortunately, is prevention. And number one, the biggest relates to the decrease in smoking in the United States. We've had an incredible decrease in the incidence of smoking. And of course, you're all familiar that smoking is a risk factor for lung cancer, but it's actually a risk factor for several other cancers as well. But that's the biggest impact, and that's great. And the second biggest impact is cancer screening. And so this is a very important component of how we are saving lives from cancer, is by early detection. There's several things that we're looking for with a good screening test. What we want is something that is very sensitive, meaning that we can detect it at an early stage, and it needs to be accurate to do that. It likewise needs to be specific, meaning we want it to identify cancer and not a whole bunch of other things, because they can be distractors, and I'll talk more about that in a minute. But we want a test that identifies cancer but doesn't identify a bunch of things that might be distractors. And then we'd like it to be cost effective and readily available, so that if we have an effective test, that people can actually get to it. We need to have access for it to be effective. So all of these things are what we're looking for to have an effective cancer screening test. And this audience, I think, is well aware of the majority of cancer screening that we have in the United States or worldwide. Yeah, I think the biggest one is breast cancer screening with mammography, colon cancer screening with colonoscopy. Then we have PSA testing for prostate cancer screening, Pap smear for cervical cancer. And the newest kid on the block, and the one that you won't be surprised that I'm talking about, is low-dose CT for lung cancer screening. And one of the things when we start to talk about cancer screening is, amongst the lay public and even amongst clinicians, we get this point that if screening is good, shouldn't we just screen everybody? That seems like it would be the best thing. That way we don't have to worry about whether we're missing it in some people. And that is a good point. But I'm going to give you now a little hint of some of the science around screening. And in the graph that is on the right side of that slide is a statistic called number needed to screen. This is a number of how many people do we need to screen to save one life. So the shorter the bar, the better on this. And so lung is the shortest bar. We need to screen about 300 people to save one life. That one life saved is really important, but the other 299, they didn't really benefit from the screening. So we have to think about the 299 also, not just the one that's saved. And there are harms to those 299. They might have a false positive test that results in a biopsy or even an operation. They might have a complication from some intervention that results. Something called overdiagnosis is one you wouldn't think of, but some people have a cancer that they're never going to die from. It's relatively indolent, slow growing, and it's not really a threat to their life. And they're going to die of something else and never die from that cancer. And of course, there's radiation exposure, as well as just the anxiety of going through testing. So screening decisions really are important to be based on a number of factors that include the net benefit regarding their age, their risk factors, their personal preferences, and their health status. So I'm going to start talking from about 2010, so just 16 years ago, where we were with cancer screening. And you can see that we had pretty decent rates of cancer screening in the United States for cervical, breast cancer, prostate, and colorectal cancer. And lung was 0. We had no screening for lung cancer, and that's because the data to that point had not really given us a reliable test that said if we did this test on a certain group of patients that we could decrease mortality from lung cancer. And why is this important? And Provost Serio said some of this, and I'm taking advantage of the fact that we have a big football game this weekend. Go Seahawks. And showing the greatest setting in collegiate football, Husky Stadium, which has 70,000 people that can fit in Husky Stadium. And nearly 2 Husky Stadiums worth of people die every year from lung cancer. You know, let that settle in, how many people that is. It's really staggering how many people die from lung cancer in the United States. And I put this graph up. The gold bar at the left is mortality from lung cancer. And in 2010, the mortality from lung cancer exceeded the cumulative mortality from the next 4 cancers combined: colorectal, breast, prostate, and pancreas cancer. So lung cancer is a huge public health problem in terms of the number of people that are impacted by it and the high mortality. So I think hopefully that will surprise some of you, but my next piece of data is going to surprise you more. The bar that's the 6th most common cause of cancer death, the one that's in gold, that's lung cancer in never smokers. Most of you thought, I thought you had to smoke to get lung cancer. You are partially right that smoking is a risk factor for lung cancer, but the only requirement to get lung cancer is having lungs. The 6th most common cause of cancer death is lung cancer in never smokers. Really a staggering statistic. And the curve on the left shows something we talk about commonly when we're talking about cancer care, and it's a curve that shows survival after diagnosis of lung cancer. And we typically use a number called 5-year survival. The 5-year survival, lung cancer is 22%. 4 out of 5 people with lung cancer are going to die from that lung cancer. And the curve on the right shows how we've improved over the past 40 years. We have negligibly from 12 to 22%. That's good, but still 4 out of 5 people are dying from lung cancer. Not good enough. And so here's some reasons why. So we didn't have screening for lung cancer. That's what we're talking about here, right? And breast, prostate, and colon cancer had increase in screening rates over that 40 years, and you can see an improvement in 5-year survival for each of those cancers, and not really significantly for lung cancer. And the graph on the right shows the ones in gold are cancers that are detected at an early stage. So breast, prostate, and colon cancer, much more commonly detected at an earlier stage, a treatable stage. The light blue in lung is how many are detected at a late stage. And the problem is that the majority of individuals with lung cancer, it's actually detected at a late stage. And this is a great time to point out that lung cancer is kind of a perfect magnifying glass of healthcare disparities in cancer patients. Lung cancer occurs disproportionately in older patients, in those of a lower socioeconomic group, has poorer outcomes in racial minorities, and it has one unique characteristic as well, and that is the stigma of being a self-inflicted disease. This is something that profoundly impacts the care for lung cancer patients, their advocacy, the access to research, and even how they're treated in society. Oh, you have lung cancer? Did you smoke? Is usually the next question. And you saw that there's a whole bunch of people that never smoked that are dying of lung cancer. So in 1999, Dr. Claudia Henschke, who's a thoracic radiologist, published this paper of 1,000 patients in the Early Lung Cancer Action Project, looking at low-dose CT to try to detect lung cancer at an early stage. And it did. What Dr. Henschke and her colleagues were able to show is they had a very high rate of detecting early stage cancer, and she postulated that you could potentially move that survival of the teens or 20% up to 80% if they could be screened. This was a game changer in terms of how we started to think about what we might be able to do for lung cancer, but it was a trial of just 1,000 patients, that's small, and was not randomized, so we didn't really know if this was what was going to change the field of lung cancer screening. But it created the groundwork for this trial, and you're going to now hear me talk about this trial a lot, the National Lung Screening Trial, or NLST, it's easier to say, was a trial that was started a couple years after that publication from Dr. Henschke. And I'm going to go through a little bit of details about this trial because this is a clinical trial in the United States and that your tax dollars paid for. This was one of the largest clinical trials ever done in the United States. 53,000 individuals were randomized in this trial. Also one of the most expensive clinical trials in the United States, $250 million to run this trial. And there's some details that I want you to pay attention to. It was randomized, which means people either had a chest x-ray, the group at the top, which we've known does not demonstrate early stage lung cancer reliably, or a low dose CT, the group at the bottom. 50-50 chance of getting a chest x-ray or CT scan. Started in 2002, enrolled patients for 3 years. They got 3 rounds of low dose CT or chest x-ray. And these were individuals at high risk for lung cancer. So also pay attention to the criteria, 55 to 74 years old, and at least a 30-pack year smoking history. So I hope you're asking, what does that mean? What is 30-pack year? 1 pack per day for 30 years is 30-pack years. 2 packs a day for 15 years is 30-pack years. So that's how we calculate a combination of smoking duration and intensity. And these are individuals that either currently smoke or if they had stopped, they had to have stopped within 15 years. So that was what we call the inclusion criteria of that clinical trial. And what happens after those patients underwent those interventions is we have safety measures in clinical trials, a committee called the Data Safety Monitoring Board that follows what's happening with those individuals, the statistics of what's happening to determine, is the trial still safe? Is there a finding that's positive that we need to pay attention to? The Data Safety Monitoring Board evaluated them and in 2010 said, we're stopping the trial. And they actually, instead of publishing it, issued a press release because the finding was significant enough that they didn't feel that there was time to put it in the peer-reviewed press, and they said low-dose CT decreases mortality from lung cancer, 20%. This was then followed by the lay press. This was in all our newspapers. It was on the news. If you were watching the news that night, you heard about this trial, the National Lung Screening Trial. And it was then published in one of our prominent medical journals, the New England Journal of Medicine, showing this survival curve, the mortality curve, showing a 20% reduction in lung cancer mortality if you had a low-dose CT for screening. And this ultimately concluded that screening with low-dose CT conclusively reduces mortality from lung cancer in this high-risk population. Remember, 55 to 74, 30-pack year smoking history. I'm emphasizing that because it comes up later. That's a heavy part of the science of what I'm talking about. And then what happens after that? Well, in medicine, we often rely on guidelines, and there's reasons for that. Guidelines help clinicians like myself know the evidence and know what to do. They help us practice in a similar way, so you're not getting something different when you go to one doctor or the other doctor if we have good evidence for what should be done. The guidelines can also influence public policy. You're going to see some of that. And it supports quality and improvement. And ultimately, the reason we do guidelines is we're trying to improve health outcomes for patients. And so now I'm going to talk about guidelines and introduce you to the National Comprehensive Cancer Network, or NCCN. The NCCN is a group of 33 of the major cancer centers in the United States. If you look up in the upper left-hand corner, you can see UW and Fred Hutch. We are one of the founding members of the NCCN. And the NCCN is known for a lot of things in its cancer management, but one of the biggest is how NCCN writes cancer guidelines, which really cover all cancers. It is the most commonly used guideline for cancer in the United States and actually worldwide. I have served on the lung cancer treatment guideline panel virtually since its inception, and I participated in this in 2010, this recommendation. I need to say this was before the National Lung Screening Trial was published, that we made this recommendation that we did not have evidence to support lung cancer screening. So I want to take a little side note here and talk about small decisions and how they can impact your career in an unsuspected way. So there was a huge discussion about lung cancer screening that year. It was a hot topic, and the board of directors of NCCN decided that they wanted to create a new guideline panel just dedicated to lung cancer screening. And they asked me to chair that panel. And I said no. So a couple points there. I said no because I had just taken on a significant leadership role here at UW, and I had other roles nationally, and I just thought, this is a huge project. I don't have the bandwidth to do it. My wife, who's here, criticizes me, not very often, but she criticizes me on one thing, that I do not say no. And so I actually went home that night, and at dinner I bragged to my wife. They asked me to do this thing, and I said no. And she kind of rolled her eyes and had another glass of wine. And this, I think, is important for younger faculty, mid-career faculty. You know, the next day I got a phone call from the president of the NCCN. And they said, Doug, we think this new guideline is incredibly important, and we really think you should chair it. Would you reconsider? My wife was right. And so I said yes. I mean, I caved, and I said yes. And if I look backwards, and it seemed like such an accidental decision, but it's had a complete impact on the last 15 years of my career and what I've been able to be involved in because I turned a no into a yes. And it shows that sometimes you don't know what's going to make an impact on your career and make a difference in your life. So while we were working on this, on guidelines, we were building a whole new guideline. The National Lung Screening Trial that I just talked with you about was published. And we were poised to publish the first guideline on lung cancer screening just 4 months after the National Lung Screening Trial was published. So this is that publication in the Journal of the NCCN. And this is the incredible panel of experts that we convened that included pulmonologists, thoracic radiologists, thoracic surgeons, medical oncologists, epidemiologists, and patient advocates. We had all this group to put their expertise into making recommendations on how we should do lung cancer screening. I know this is a busy slide, it's purposely busy. This is just a page from that guideline that shows the algorithm of how we said these patients should be screened and these people should not be screened. That was published in 2012. So I thought, we're done. We have the science and we have guidelines. Let's start screening. And I was wrong, dead wrong. So it turns out that medicine is like many other things. If nobody's paying for it, it isn't going to happen. And nobody was paying for lung cancer screening. It didn't matter if we had evidence, and it didn't matter if we had guidelines. If the policymakers have not made a decision to pay for it, it's not going to happen. So part of that policy is driven by the United States Preventive Services Task Force. It's a mouthful, so I'll call it USPSTF. And it's an independent panel of experts in disease prevention, and they're the ones that make recommendations for screening or other preventive services. And it's very powerful because under the Affordable Care Act, if they make a recommendation for screening, then private insurers have to pay for it. So what about USPSTF? Well, they actually made a recommendation about lung cancer screening in 2004 and said, no, there's not sufficient evidence that any screening modality decreases lung cancer mortality. So nobody's paying for it, that's why. And so this led to a whole different level of activity that included trying to bring awareness about the evidence and the guidelines and what we should be doing. And that included Washington, D.C., meeting with members of Congress, testifying to a Senate briefing in order to try to bring awareness for USPSTF to reconsider their 2004 guidelines, which they did. And in 2013, on December 31st, they changed their guidelines and said, we recommend annual screening for lung cancer. So, victory. It'd be nice if I could stop the talk there. We could say, USPSTF said, okay, so we can now screen everybody. And that was the next phase of me learning about how naive I am about healthcare policy. Because Medicare is the largest insurer in the United States by far, and lung cancer patients are dominantly Medicare insured because most of them are older, so they're in the Medicare patient population. And what I learned is Medicare doesn't follow USPSTF. They've got their own thing that they do, and that's called the Medicare Evidence Development and Coverage Advisory Committee, MedCAC. And they're the ones that make recommendations about whether Medicare will provide a preventive service like screening. And MedCAC does their work through having a panel. This is a MedCAC panel. This was April of 2014. And this is the actual panel that was having a hearing about lung cancer screening. I testified at that hearing as well as many others. And shockingly, at the end of that hearing, they voted against lung cancer screening. They decided not to do it. I will say that that was an incredibly dark day for those of us caring for lung cancer patients and in this space advocating for lung cancer screening. For 24 hours, we cried and moped, and then we put our act together and said, we're not accepting this and we're going to fight. And part of that was public information. An example being this editorial in the Wall Street Journal. Another part is working with members of Congress, both the House and Senate, and making them aware so that they would bring some political pressure to bear on Medicare administrators about lung cancer screening. That's all good, but really the most important part was what occurred with a collaboration between leaders from the American College of Radiology, the Society of Thoracic Surgeons, and the Lung Cancer Alliance, the last being a patient advocacy group. And we worked together meeting in Bethesda with Medicare administrators to educate them about the data, and maybe just as importantly, to work with them on how they could implement lung cancer screening nationally in a safe and effective way. And on February 5th of 2015, Medicare issued a national coverage decision paying for lung cancer screening. To my knowledge, this is the first time that Medicare has overturned a recommendation from their own coverage advisory committee. And this is now really huge because 70% of lung cancer patients are Medicare beneficiaries. So this was finally a big day that we have both private and public insurers paying for lung cancer screening. So I started you in 2010, and now we're up to 2015, just 11 years ago. And we have lung cancer screening as a significant mortality benefit. We have private insurers that started covering January 1st of 2015, and 1 month later, Medicare beneficiaries being covered February 5th of 2015. So just 11 years ago. This is all recent news. And I'm going to say that because of the impact and some of what you've seen already and what a dominant cancer mortality impact that lung cancer is, this probably has the biggest impact not just on lung cancer management in a generation, and apologies to my colleagues who treat other cancers, this is probably the biggest impact for all cancers in terms of its ability to save lives because of so many lives being lost by lung cancer. So if we move forward, how does that look? And so I'm going to tell you a little, how does that apply and how does that evolve now from there? So if we apply that criteria that were developed at the National Lung Screening Trial and then adopted by Medicare and USPSTF, only 27% of lung cancer patients are eligible. So it's a great start, but we're missing 3/4 of the individuals that are still going to get lung cancer. So it's a good start, but not good enough. And our lung cancer panel in the NCCN anticipated this. And I'm going back to that page that I showed you as busy before to give you a little more detail. Up at the top, this group called NCCN Group 1 was really like the group that we studied in the National Lung Screening Trial. But that panel of experts that I showed you said, there's other people that are at risk for lung cancer. It's not just these. And we added NCCN Group 2 and recommended screening for them, individuals down to age 50 and with a less smoking history of 20 pack year. We did that with the very first guideline that we issued in 2012, and I will tell you, it was quite controversial, meaning I and others on my panel took a lot of heat, feeling that this was too big, that we were going too aggressive about applying lung cancer screening. But if we use the criteria that was studied, we would have about 9 million individuals in the United States eligible. And if we screened them, we could save about 12,000 lives per year. If we add that NCCN group 2, it adds another 3,000 individuals, 2 million individuals and another 3,000 lives saved per year. Those were the reasons that the NCCN panel said, we need to expand the inclusion criteria for screening. And fortunately, around this time, there was another publication from Europe. This is a really important study from the Netherlands called the Nelson trial that also looked at low-dose CT screening for lung cancer screening, and also published in the New England Journal of Medicine, and actually had results better than the American trial. In the Nelson trial, the mortality reduction for men was 26%, and the mortality reduction for women was 39%. A huge impact in decreasing lung cancer mortality in the Nelson trial. And with that additional data, in our NCCN guideline panel, which we review and update annually, we doubled down on this criteria and said, we're going to simplify it even more. We're going to make it easy to figure out how to get people into screening. We're going to get rid of all those complicated criteria and just say, if you're 50 or older and smoked more than 20 pack a year, you're eligible for screening. And because we did that, we went back to the drawing board with USPSTF and Medicare and said, that guideline that you did, we would like you to reconsider and make it better. And in March of 2021, USPSTF did make it better. And they changed it to be very similar to what we had recommended in the NCCN guideline, age greater than 50, smoking exposure greater than 20 pack year. It was just 10 years later. But remember, there's also Medicare. They did it too. They were just a year later. They were in February of 2022, but they got on board as well and said age greater than 50, smoking exposure greater than 20. So we've actually moved the needle on extension of lung cancer screening closer to what the NCCN had recommended in 2012. So I want to show you a little more science of what has happened since we started screening for lung cancer. The graph on the left is early stage lung cancer, and the inflection point is when we started screening. And what you see in that graph is when we started screening, we started seeing more people with early stage cancer. What you'd like to then also see is the graph on the right, which is people with late stage cancer. And what we see at that same inflection point is we're starting to see fewer people with late stage cancer. That's exactly why we're doing screening. We're trying to catch more people that have early disease on the left and have many fewer people with late disease that you see on the right. You remember I showed you that 5-year survival graph at the beginning of the talk that you have on the left, and it was 22%, and we bemoaned how bad that was. I wanted to show you this graph, which is a graph from the International Early Lung Cancer Action Project, that is lung cancer mortality in those in a screening program. Their survival is 84%. So, on the left, what we had before screening, 4 out of 5 people died from lung cancer if they were diagnosed. The opportunity here is if we're good at screening people, 1 out of 5 dies from cancer. And those of us that are in the cancer space that are used to looking at survival curves like this, there are very few interventions that we have that invert a survival curve. This is a true inversion of a survival curve from 22% to 84%. So this is an incredible difference in potential if we can screen people for lung cancer. So I'm going to come up to the present day. And where are we? This paper was published 2 months ago from the American Cancer Society. We are screening approximately 19% of the people eligible for lung cancer screening. 19%. That's the bad news. The good news is, even if we only screen 19%, we still save 15,000 lives over 5 years. Well, that's good. But what if we did better? What if we screened all of those people that were eligible? Then they modeled we could save 60,000 lives over 5 years, a 4-fold increase. And what if we added that group that the NCCN has recommended, additional individuals with a smoking history? That'd be another 27,000. Then we'd save almost 90,000 lives over 5 years. That starts to sound like real lives being saved. And the recommendation from this paper is we ought to reconsider the eligibility criteria. And this was a big enough article in JAMA that there was a big New York Times article the same day that came out. And my comment in that article was that the number of lives saved by early detection completely eclipses the lives that we save with drugs or radiation or surgery. And we followed with an op-ed in our own Seattle Times. This is from the Seattle Times. And why are so few people getting lung cancer screening? There's a lot of reasons. I don't have time to talk about all of them, but I want to concentrate on the ones at the bottom about complicated eligibility criteria or restrictive eligibility criteria. And go back to the greatest setting in collegiate football. So approximately still half of the people that get lung cancer, only half of them would be eligible for screening. It's better than the 27% that I showed you a while ago, but it's now only up to 50%. And so we made some recommendations in this op-ed of things that we could do. And I'm going to just talk about one of them because I really emphasized earlier this whole point about pack years and how we calculate them. And this aspect of using a simpler smoking metric. One of the challenges for us, you'd be surprised in our healthcare business, it is hard for us to measure pack years. It's very difficult to capture in our electronic medical record. People don't remember how much did I smoke and for how much. So it's been considered, should we consider just how many years did you smoke instead of how many years and how much did you smoke? And this is an important study from Alexandra Potter and her colleagues that looked at individuals in the southern United States, and this was particularly focused on a black population from the Southern Black Cohort study. And the graph on the left, the way to look at this is a blue dot is someone with lung cancer. And if they are in the white box, that means they were eligible for cancer screening. So 62% of black individuals were eligible for cancer screening if you use a 20 pack year criteria. So then it was, what if we got rid of the pack year thing and just said 20 years, make it really easy, everybody can figure that out. Then we moved this to 92% of black individuals were eligible for lung cancer screening. So there's several things that I want to emphasize from this. That first, this smoking duration metric does a better job of connecting people who are going to get lung cancer with getting screening. And second, it is one of the most effective tools we have in improving healthcare equity in this space, because it turns out that black individuals on average smoke less intensely than white individuals. Yet they still get lung cancer. And they have been disenfranchised in our guidelines to date with lower rates of inclusion for black individuals. And this metric would improve that. So at the NCCN, we thought this was important enough last year to say, we're going to change our guidelines and make it 20 years instead of just 20 pack years, because we think it's better for everybody and better for healthcare equity. So I showed you the slide already about the record-breaking drop in cancer mortality in the United States. And now I'm emphasizing that that drop is driven by all cancers, but dominated by lung cancer. And if we look at the relative impact of each cancer on the decrease in cancer mortality over the past 30 years, the biggest one is lung. And it's because lung has the most mortality. And a lot of this, fortunately, is also prevention by decreasing smoking rates. I've also just been talking about the United States. But of course, lung cancer is a global problem. And so this is additional work that we've done with the World Economic Forum, focusing on the World Health Organization Sustainable Development Goal 3.4, which is to reduce mortality from non-communicable diseases, including cancer and lung cancer. And this led to these recommendations for global access to lung cancer care, that all countries should add early detection and treatment of lung cancer to their national control plans, because it's the most effective and implementable way to save lives. So moving it from United States policy to recommendations through the World Economic Forum and WHO. And you won't be surprised that we're not finished with communicating to USPSTF and Medicare, asking them for these further improvements in the eligibility criteria. And advocacy is still happening regularly. This is about a month ago, a meeting with representatives from the Congressional Black Caucus on a Zoom meeting from my office here, and talking with them about cancer screening, and particularly, of course, about healthcare disparities in cancer screening. And as I wrap up, I've tried to emphasize that we're trying to balance the relative benefits and harms. We don't want to screen everyone, because if you're not at high enough risk, we can harm you by screening you. We also don't want to miss out on screening people that could benefit from early detection. And I hope I've emphasized that, at least right now, the balance is uneven, that we are not screening enough people that are at risk for lung cancer and not doing a good enough job of getting them in to be screened. So I'm going to wrap up with my last football analogies prior to the Super Bowl. If we used TSA level screening to get into the Super Bowl or to Husky Stadium, at the end of the game, everyone would still be in line and 19% would be in the stands having seen the game. The game was over and only 19% are sitting in the stands. They missed the game. But this is just football. It's not their life. If we make it easy for them to get into the football stadium, we can fill the stadium, everybody sees the game. They still have to have a ticket to get in, but we needed to make it easy enough for them to get in that they could have access, in this case, to a football game, or in the case of lung cancer screening, a chance for early detection and a chance to save a life. And so I'm going to come back around to Barbara. I started with Barbara, and I'll end with Barbara. So I operated on Barbara, I told you, in 2006. It's 2026. Barbara called me about 2 months ago and said, Dr. Wood, it's coming up on our 20-year anniversary, but I actually need your help with something. My cardiologist told me I need a new heart valve. Barbara doesn't live in Seattle anymore, But she said, I want to come to UW Medicine for my heart valve. And so I helped her get set up with the right people. She had her heart valve. She sent me this picture. Barbara was 54 when I saw her in 2006. She's 74 now. She might be a little mad that I tell you that. And Barbara's online. I know she wasn't able to be here, but, and look at her. She's healthy, strong, happy. Barbara is an example of why we're doing this, because we're trying to take lung cancer victims and turn them into cancer survivors. Thank you very much.
Thank you, Doug, for that awesome talk. Good evening, everyone. My name is Farhood Farja. I'm a professor in the Department of Surgery and endowed chair in lung cancer research. And I'm your moderator for the evening. But first, a few words. Doug, we first met 23 years ago when I sought out some career advice from you. And what eventually came from that meeting is we became partners, caring for patients, collaborating on scientific investigations, and training the next generation of thoracic surgeons. And I think it's bold, courageous, and straight up awesome that you became a leader in practice guidelines, patient advocacy, and health policy. And I think that that work extends your impact well beyond the average academic surgeon. So congratulations and thank you.
Thank you, Farhood.
So we got some questions in advance of the meeting, and I want to encourage you all to submit questions. So I'm going to give you an email address, and I'm going to give you a phone number, and you can email or text. Oh, there you go. So questions at UW, 206-616-8160. So I'm going to start with one of the questions we've already received. And you spoke a little bit about this, but I'm hoping you can expand on what are the barriers to lung cancer screening, and what can we do now to overcome some of them?
Yeah, that's a great point, Farhood, and thank you for the nice words. And I talked about how we're moving the access, and there's a lot of factors in play. Some of it is just knowledge that lung cancer screening exists. It's still new, so it's not widely recognized like, for example, mammography is for breast cancer. So awareness, education is a component. If I focus back on those points about eligibility criteria, I'm going to emphasize three. So the most significant one I'll mention here is, remember I told you that if you had stopped smoking for more than 15 years, that you were not eligible for screening? There's no data to support that. If you've stopped smoking 16 years ago, it's the same as if you stopped 15 years ago in terms of your risk for cancer. And in fact, the largest reason that people are not eligible for screening that still get cancer is this one, is the 15-year quit date. So we tell them, you need to get rid of that. In fact, paradoxically, it implies that you could resume screening if you could start smoking again. Well, that's crazy, and so we don't think that that's a good policy. And then there's another one that is a top age of 80. Well, I'm operating on people in their 80s all the time. They're strong and they deserve the same access to early detection and treatment that somebody that's 65 or 75. And we don't think that should be a policy limitation. That ought to be a discussion between a patient and their doctor of whether they want to be screened and whether they're healthy enough. And then the the other one is the one that I mentioned more here about using a smoking duration metric instead of a pack year metric, which is more complicated and also less equitable.
So what do you anticipate in terms of advancements in lung cancer screening in the future?
Yeah, that's a great question. And the good news is there's a lot of really smart people that are doing research in different types of technologies that can expand what we're doing with low-dose CT. Low-dose CT is great because it's easy to get, it's fast, it's safe, it's implementable, but it's still, you get radiation and you still need an appointment to get it. If there was a blood test or a breathing test that could detect it, and we're examining both of those things, then we might have a supplement to the CT scan that would be maybe cheaper, easier to apply, and more accessible to a broader group of individuals. I actually see that happening. I'm not sure the time horizon, but there's a lot of researchers and industry that is doing research in this area.
So you're touching on the diagnostic modality. There's some stories shared here too, and a couple people have shared that they've lost family or friends who are in their 20s and 30s, and you've already talked about expanding the indications, but can you speak a little bit about the future of lung cancer screening in terms of expanding further?
Yeah, whenever all of us taking care of people with lung cancer have a significant group of patients that we've cared for that never smoked. They often have a family history or a genetic characteristic that puts them at risk for cancer. So far, we've not developed a way to know how to screen that group effectively, but I think we will hopefully be able to do that by identifying the genetics, the family history that could go beyond just the smoking history in terms of indications for screening. Right now, you still have to have a smoking history, but I think family history or some genetic factors that we can identify reliably may be a way of extending those criteria in the future.
So then here's a sort of a practical question. What happens when a person has a screen-detected lung nodule? What's next?
Yeah, that's something I didn't touch on at all. What happens when you get a scan and something is found? Well, interestingly, the majority of spots that we find in the lung are not cancer, so that's good news. But the challenge is we need really smart radiologists to help tell the rest of us which one should we look at more aggressively or not. I married one of them. My wife is a thoracic radiologist, and so that's my secret weapon is having that right at home. But it's important then, I think, to have a process for how those nodules are evaluated systematically to avoid unnecessary testing or biopsies or surgery on people that don't have cancer, yet to do a good enough job of evaluating those nodules that do look suspicious for cancer, that we're taking advantage of the early detection and treating them early. So what I didn't show you from the NCCN guidelines, and that is quite similar to a guideline from the American College of Radiology called lung RADS, is we actually have algorithms for how to manage lung nodules. Lung RADS from the American College of Radiology, the algorithm in NCCN, have a path for how somebody like me could look at a CT scan and say, this kind of nodule, what we're going to do is we're going to do another CT scan in 3 months. Or this one, we need to biopsy or get a different type of x-ray. So we actually have a nicely protocolized way to manage those that if one is disciplined about it, I think we do a pretty good job in filtering the benign lesions so that we don't do too much to them, and filtering the malignant ones so that we treat them appropriately.
So in the same way that you were talking about the balance between the harms and benefits of screening, you're basically describing the same thing for what happens after the person has the nodule, and lung RADS achieves that goal.
Yeah, you're right. That's a great way to put it, is screening is not a procedure, it is a process. It's the process of being screened and then managing the screened findings, but it's also a process of continuing to be screened, because you need to be screened then every year reliably to get the full benefit of doing the testing.
So there's a response here, a comment here about a gentleman who shares a story of his wife getting screening mammography right on time, as recommended, and unfortunately and sadly diagnosed with lung cancer. And so I guess the question is there a way to leverage screening for other cancers to increase the uptake of lung cancer screening?
Yeah, that's a perfect question, because actually in the United States, the screening for breast cancer is really highly organized, very well known, protocolized, and women fairly reliably get mammography for breast cancer screening. And some have been intentionally partnering, leveraging the experience of mammography to try to also get women into lung cancer screening, setting up women that are going to get mammography and have a smoking history to potentially get their low-dose CT scan on the same day that they're getting their mammogram. Those are kind of unique programs, but is an example of how we can take the benefits of what we have from one screening modality and potentially leverage it, in this case, to an underutilized screening modality, lung cancer screening, and potentially increase it, certainly for women.
So a question that we get when we take care of patients is, what would you do for your own family member or friend? So if you had a family member or friend who might be eligible for lung cancer screening, what would you tell them?
Well, I think the decision to embark on screening is a personal decision. It's not necessarily what everybody wants to do. You have to think about, what am I going to do if? What if I find something? What am I going to do about that? And so I think it's an important discussion for that individual to have with their primary care doctor, to discuss with the person that they trust and has some knowledge of the evidence, to talk about the pros and cons, and then to advise them, if they're eligible for screening and want to do it, to make that referral to get into a screening program.
Thank you, Doug. Thank you very much. And I want to thank everyone in the audience who attended this evening. And this concludes this year's university faculty lecture.
Thank you.